Hello, my name is Tyler Bonkowski. I'm an internal medicine resident at Spectrum Health, and I would like to present an interesting case of a clot caught in transit. Prior to birth, a small communication exists between the right and left atrium of the heart, called the foramen ovale. This allows blood to bypass the fetal lungs and shunt directly into the systemic circulation. This opening normally closes shortly after birth. However, it remains patent in 27 to 34% of the population. The most feared complication of the patent foramen ovale is a paradoxical embolism, where a blood clot from the venous system traverses the opening and embolizes into the arterial circulation. The frequency of this event is difficult to quantify, as it is largely a diagnosis of exclusion. The mismatch between the frequency of PFO and paradoxical embolism may be in part due to the abnormal physiology required to set up this event. Elevated right heart pressures, such as during acute pulmonary embolism, increases the patency of the foramen ovale. This likely contributes to the 5 to 10 times higher mortality rate observed in patients with PFO in acute pulmonary embolism. On the right is a transesophageal echocardiogram. Circled here in yellow is the patent foramen ovale, and you can see a Doppler color jet which shoots from the right atrium into the left atrium. So our patient was a 45-year-old male with a history of obstructive sleep apnea and obesity who presented with 1 week of shortness of breath with exertion, as well as some chest tightness. This had rapidly progressed over the past 24 hours, to the point where he was unable to ambulate from the bathroom to the kitchen. When he arrived in the emergency department, he was found to be hypoxic, requiring up to 4 liters via nasal cannula, as well as tachycardic but normotensive. His initial EKG showed an S wave in lead 1, as well as a Q wave and T wave inversion in lead 3, suggestive of right heart strain. His cardiac biomarkers were significant for an elevated high sensitivity troponin, as well as an NT-proBNP. Given the constellation of these findings, there is high concern for pulmonary embolism, so a CT angiogram of the thorax was performed. This showed a large saddle pulmonary embolus extending into the lobar and segmental branches with, again, evidence of right heart strain. That pulmonary embolism is highlighted here in yellow on the left. The patient was started on a heparin infusion and admitted to the hospital. After a multidisciplinary discussion, the decision was made to go forward with mechanical thrombectomy. Pulmonary artery pressures via right heart catheterization measured 90/32, which subsequently improved to 80/27 post-thrombectomy. Following the procedure, a transthoracic echocardiogram was performed as shown on the right. A large 4.6 centimeter thrombus could be seen traversing the PFO and extending into the left atrium, across the mitral valve, and into the left ventricle. At this point, the patient was transferred to our institution for consideration of surgical intervention. The following day, a transesophageal echocardiogram was performed, which could not identify any intracardiac thrombus. The patient had no change in his neurovascular status clinically, therefore the hunt was on to try to find this clot. A whole body CT angiogram showed that the clot had eventually landed in his right popliteal artery. Ankle-brachial index was abnormal on this side, therefore mechanical thrombectomy was performed. The following day, an inferior vena cava filter was placed, and he was eventually discharged on rivaroxaban. This case provides several learning points. First, PFOs are common, yet paradoxical embolism is rare due to the need for concurrent right-to-left pressure gradients to facilitate clot transit. A high index of clinical suspicion and early echocardiogram can help identify PFO in acute pulmonary embolism prior to intervention and may change management. Our patient was extremely lucky in avoiding a catastrophic cerebrovascular event. Multidisciplinary discussions are important for management. The optimal treatment of these patients is not currently known, although reviews of the current data have shown a trend towards improved survival with surgical management and increased mortality in those receiving systemic thrombolysis. Lastly, timely investigation is necessary to identify and treat systemic embolization, particularly in those without blatant clinical evidence for embolism, where advanced imaging may be required. Thank you for your time.